Good morning, everyone. Thank you for joining us for Pediatric Grand Rounds today. Our speaker today is Dr. Kathryn Bass. She is the Section Chief of Pediatric Surgery at Carilion Clinic and a Professor of Surgery at the Virginia Tech Carilion School of Medicine. Dr. Bass was educated as a biomedical engineer at Northwestern University, obtained her medical degree from Northwestern, and more recently completed an executive MBA also at Northwestern. She trained in general surgery in Boston, pediatric surgery in Denver, and has gained additional boards in wound care with a focus on research to mitigate scar and dysfunction following burn injury in children. Dr. Bass joined Carilion Clinic last September. Happy first anniversary. She has been practicing pediatric surgery for 24 years, including management of common neurological problems in children. Today she will speak on the diagnosis, surgical management, and follow-up of the undescended testes. Please join me in welcoming Dr. Kathryn Bass.
Thank you so much. So, no financial disclosures. This morning we're going to cover the areas of terminology, how we talk about undescended testes, the indications for referral, its natural history, complications and sequelae, the management, mainly surgical management, and some of our recent professional society guidelines, a resource for information for patients, and we'll try to summarize and be done a little bit before 8:30 so we have time for questions. I am going to attend a clinic at 8:30 this morning upstairs, so we'll try to be timely. It's a lot of information and it's a lot of repetition. This is how we learn, by hearing things and hearing it again, and so throughout the talk we'll touch on what the key points are. So undescended testes or cryptorchidism is the most common congenital abnormality of the genital urinary tract. So most of these testes will be undescended in this category, but some just don't form or are atrophic. The true undescended testis has stopped along its path to the scrotum. It's either on that highway and just arrested in descent, or it detoured off the path, or just never made it out of the abdomen. So these testes can be, they're not seen in the scrotum, and those that don't descend to the scrotum, we expect to see them by 4 months of age, so we give them a little bit of time. But again, if they're not there, we start thinking, are they absent? Are they somewhere along that pathway, or have they suffered some kind of in utero demise? So just to refresh a little bit about the anatomy, the testes has its own blood supply, which runs along, beginning in the abdomen, down the inguinal canal to the scrotum. The cells within the testes are going to be both contributing to fertility and to virilization. The caput epididymis can be felt on a physical exam, and it has both a head, a caput, and a tail, a cauda epididymis. It's connected to the vas, which then delivers the sperm. So when the testis is absent, there are several reasons that could be so. Could just simply not have formed, or there may have been some intrauterine vascular compromise. This might have been because of torsion. We sometimes talk about this as a vanishing testes or regression syndrome. And a little bit about the anatomy, so we're talking the same language. The floor of the pelvis, where all the abdominal wall muscular inserts into the bony pelvis, we call the inguinal canal. And that inguinal ligament is just the confluence of all those tendons that are going to attach to the bone. There is a deep or internal ring and a superficial ring or external ring, and that is the pathway that the testis will travel to get to the scrotum. So when we put in a telescope and we're doing laparoscopic surgery, this is the view that we get, and you can see that there to the right of your screen are the indirect defects, and that opening that you're able to perceive and label is the indirect or internal ring where the testis is going to descend. So again, the testis begins in the abdominal cavity, makes its way down. When it's in the inguinal canal, it many times is palpable, but sometimes is present but cannot be palpated. We call that location the intracanalicular location. And many times the testis will make it through the ring and then land just outside the external ring, in line with the inguinal canal, either to the right or to the left of that external ring, or it can be in what we call ectopic locations when it's not exactly on that path. And the way we perform the physical exam, many times we use the term milking, which I'm not sure why that particular verb is used, but it's basically using the pads of your fingers to gently pull down the testicle along that inguinal canal to see if we can get it to present itself visually and under palpation into the scrotum. Now, undescended testes can be confused with retractile testes. The spermatocord that runs along the inguinal canal has premasteric muscles that run longitudinally. Their job is to pull the testes up out of the scrotum, either to cold, fear, or palpation. But we can do a physical exam to assess that, and we'll talk a little bit more about that. The ascending testes are those that were in the scrotum early in childhood, but then over time become unpalpable or become higher, begin to ascend that tract. And so again, just a visual of where the testes may arrest, the normal on the far right, in the left hemiscrotum, and then on the left of your screen, the abdominal location, the inguinal location, and the high scrotal location. So when are you going to think about sending these babies for evaluation, or these boys? When you can't feel the testes on either side, when there's only one that's palpable, when the opening for passage of urine, the meatus, is either not in the right position on the glands, whether it's low or high on the ventral or dorsal aspect, hypospadias or epispadias. And these bring up the subject of suspected disorders of sexual development, and specifically congenital adrenal hyperplasia. So just a little bit about that. That's an entire another talk to give. But by the 6th week, the gonads are developing and they're not yet differentiated. If there is an SRY gene, then the testes, the gonad, will develop a gubernacular reaction, and that is that connection, that highway that's forming to the scrotum that the testes is going to travel along to, so that by the 25th week, it has passed through the inguinal canal and is now in the scrotum. If the SRY gene is absent, then the gonad is destined to become an ovary, and different attachments will form, the ovarian ligament, and the other female reproductive organs, uterus and fallopian tube around it. And what you will see phenotypically, again on the far left of your screen, is the normal female with a clitoris, labia, and within the labia, the urethra and vagina, with the anus sitting more posterior towards the coccyx. On the far right, the phenotypic male with the urethra positioned in the glans, a phallus, and bilateral scrotum. And in between is that ambiguity of the congenital adrenal hyperplasia with a enlarged clitoris and an opening that may represent urethra and vagina, and a true cloaca would be that one opening would also involve the anus, or a CAH, which would be the anus more properly located between the gluteal cleft, just above the coccyx. So, if we have bilateral non-palpable testes, just start thinking about DSD, and we want to start the evaluation, a hormone evaluation, refer for surgical evaluation, start imaging, and ultrasound is your preferred imaging modality. And just to refresh, what happens during congenital adrenal hyperplasia is the lack of 17-hydroxylase, which becomes an endocrine crisis because aldosterone and cortisone aren't being developed, and the cholesterol is being driven towards androgenation in terms of sex hormones. So when we don't feel the testicle and 4 months is arriving, we start screening, doing repeated monthly exams, educating parents about what to look for, and I usually recommend the warm tub bath test to see whether the testes will come down and be visible or palpable. And that's for whether you find one on one side or you don't find one on either side. Another reason why we're interested in getting the testicle identified is because of torsion and the risk of torsion in the undescended testicle. So again, we start to look for it with ultrasound. The ascending testes are those that are found in the scrotum, present on the newborn exam, but become difficult to find over time. And again, then we start employing that algorithm of look for it with an ultrasound, start educating the parents, use a warm tub test. Sometimes there's tissue in the scrotum, but it feels smaller than the contralateral side or qualitatively different. And again, that's another reason to start imaging, start doing monthly exams, and do that warm tub test. And this is an example of a testis, the one labeled 2010 that might be retractile on the right, that arrow on the far left of the screen. And then a year later, that testis on the right is in normal position, but the testis on the left is starting to ascend. So just to underscore, repeated exams of the genitalia are needed. So again, what you're gonna try to do is milk it down or use the pads of your fingers along the inguinal canal to try to palpate. And if you do palpate, drag it down to the scrotum. If you can get it to the scrotum and hold it there, that's a good sign. If you release it and it rebounds, that generally portends an undescended testis. So again, just another depiction of where the testes, where the gonad starts, up under the kidney. So it's got a pretty long way to descend. Starts developing at 7 weeks. It starts descending by 12 weeks, and by 4 to 6 weeks before birth, it should be somewhere near the scrotum. And remember, this is important because for preterm infants, we're not going to find the testes in the scrotum. They're not yet scheduled to arrive. So we have to look for them, palpate them, and do repeated exams. And I think it's important to keep in mind that that the undescended testis is important to diagnose because timing becomes very difficult. Because if we get to them before a year, we can allow partial catch-up of volumetric growth. And if we find a testis that's hypertrophic on one side and small on the other, it should trigger in your mind the thought that maybe this small one could benefit from being descended. So when we take a look with the laparoscope, what we're looking for is the hardware that the testis needs. So on your screen left, you're going to see the vas deferens with its singular blood supply running parallel to it, and that's coursing from medial to lateral to that internal ring. And then you see all those hardy testicular vessels that are in the near 6 o'clock position in this image. But that internal ring looks closed there. So we know at least there's hardware there for the testicle to develop beyond the internal ring. What do we know about the impact of fertility in undescended testes? It really comes from a lot of the work done early in urology, before we had IRB and consideration of human research. All of these testes were biopsied, and so we started to learn about, timing of the surgical intervention and what that meant. And so fetal gonocytes are transforming to adult-type spermatocytes during those initial 4 months, and they're very distinct histologically. And in order to do that transformation, they need the environment of the scrotum. So fetal gonocytes, if they are not positioned in a proper environment, fail to follow that path of transformation to adult spermatogonia. And by 1 year, this germ cell density difference is apparent. And by 2 years, 30 to 40% of these testes don't have spermatogonia. So this is what we're looking for, those robust rosette-like cells on biopsy. So What's really fascinating is that if you have a unilateral undescended testy, it is going to affect the contralateral side. So in these series of biopsies, what was learned was that the contralateral testes was also affected only 15% spermatocytes. And that this carries through to puberty. In other words, the effect of hormones at puberty does not change this. So a delay in the descent of the testis does impact fertility by a year of age. And again, that's all documented by these historical biopsies. So again, that 4-month inflection point is very important. And just doing routine general exams on boys is important. Defer to the surgical consultant. Start doing the ultrasound exam. One thing I'll say in our system that I would encourage you to do is when you're sending for surgical consultation, the surgeon, that would be me and my partner, prefer to have access to the radiology, not just the report, and we prefer to actually talk to the radiologist about what they're looking for, because the radiologist and the technician, those two factors really impact the outcome of that exam. Here's a summary of all the histologic classifications in these biopsies. 12% had normal histology, hypospermatogenesis in 8%, the semicytotic arrest in 28%, Sertoli cells only in 34%, fibrosis in 6%. So, what are the things, complications and sequelae that occur in the undescended testes? Inguinal hernia is very common. As we said, that's the highway that the testis has to travel. Torsion is also increased. Subfertility we've talked about, and also testicular cancer. So what's the problem with inguinal hernia? Well, that open internal ring is not only a highway for the testis, but also puts the viscera, the small bowel, the colon, the appendix, in the girl, the ovary at risk of descending and entrapping and incarcerating. So how do we manage that? Well, nearly all undescended testes do have a patent processus vaginalis, which is how we define an inguinal hernia. And in general, it's been our culture to fix the hernias when we find them, when we have inpatients, at about 2 kilos and before patients go home. That's to avoid the risk of incarceration in the premature. And so, these days we're sending kids home even earlier than 2 kilograms. And so we do have to, this is sort of a trend that I've seen in our nursery. So we got to be really careful. If you get these very small preemies in your office and you see they have hernias and they're less than 2 kilos, I'd start to refer them so we can get ready to get them repaired. What about testicular torsion? It's up to 10 times more common in the undescended testes than the unaffected testes. Of course, it's a surgical emergency, and the salvage of these undescended testes is, in our literature, less successful, probably due to the delay in diagnosis because they're not able to be very well seen. And how do we prevent torsion? By fixing the testicle during the surgical repair. Now, tumors will also increase the risk of torsion, and that's just because of abnormal shape. As we talked about, the testes are suspended on vessels, very compliant tissue, and they have a tendency to have like a wringing out motion because they're suspended like on a pendulum, and the 360 motion is very easy to accomplish. We do use ultrasound as the primary modality to evaluate the testes, but you can't hang your hat on that and don't delay the treatment of it because you're waiting for an ultrasound. Unfortunately, both for the ovary and for the testicle, there can be flow, there can be decreased flow, and the testicle can be torsed. So if you've got an acute event with pain and swelling, the default diagnosis is torsion, and they need urgent surgical evaluation and an exploration. Trauma in the undescended testicle is also a greater consequence because those that are in the intracanicular position in the inguinal canal are at risk for crush injury because how they are positioned over that bony pubic ramus. We talked about subfertility, and this comes also data from infertility clinics where men who have a history of undescended testes have lower sperm count. These also include men who have a history of retractile testes. So a little bit nuance of this diagnosis, but retractile testes that live high or, in the high scrotum can benefit from descent. So what does the maturation of the gonocyte look like and its timing? So it follows this pathway so that you can see on the left the cartoon of maturation and on the right the impact of undescended testes, which basically decreases the amount of germ cells that are going to progress to spermatocytes. So again, we've learned that if we intervene before 12 months, before 24 months, we have some ability to impact fertility. And this has really been demonstrated to be positional, so worse fertility with higher level of position in the abdomen. But the testes is also providing another function, which is the androgen hormones and virilization. And so what do we know about that with regard to the undescended testes? Well, we've talked about the fact that we will experience subfertility if the testicle is undescended for greater than 12 to 24 months. And we know that through monitoring the FSH and the inhibin B. So FSH, when it's elevated, is a marker of Sertoli cell and seminiferous tuberal dysfunction, whereas inhibin B runs the opposite direction. When there is a decreased serum level in the inhibin B, it's a marker of Sertoli and seminiferous tuberal dysfunction. So fertilization is decreased when we see these elevated FSH or a depressed inhibin B. But the virilization is unaffected. So the Leydig cells are able to produce androgens, whether they're high in the belly or whether they're low in the scrotum. So we've been able to demonstrate that early orchidopexy less than 2 years will lower the FSH levels, higher the inhibin levels, and improve fertility outcomes. And that the studies that show later orchidopexy between 2 and 12 years old have lesser fertility compared to the cohort repaired earlier. So there is an advantage to earlier orchidopexy. The same is true with the progression of cancer. So there's been many studies done, the meta-analysis done in 2013 with 9 case controls, 2 million boys, 2,281 cases, showed this wide range of increased relative risk from 3 to 50, probably just reflecting the quality of all those studies, but clearly there is an increased risk. And really the most common thing that's found is germ cell neoplasia in situ, which again is a kind of a call for early screening and earlier intervention. And that if we position the testes in the scrotum before puberty, that we can demonstrate a decreased risk for cancer, but it does not eliminate the risk for cancer. It just means we have the testicle in a position where we can monitor it and follow it. And that was done following long-term outcomes between over 30 years, 69 to 99, demonstrated that orchidopexy before puberty decreased the relative risk for cancer, almost in half. So another good reason to refer early. And then these observational studies following men with history of undescended testes basically identified that, again, this fascinating concept that the testes are related, that the unaffected testes is impacted also in the category of cancer, that 42 tumors on the unaffected side were discovered with testicular cancer, which is a higher rate than found in the general population. So how do we manage the undescended testes surgically? We fix the testes in the scrotum, and if we find anything on our exploration that looks rudimentary or unviable, it's resected because of its malignancy risk. So our goals are to reduce the risk of torsion, reduce the risk of trauma, reduce the risk of infertility, reduce the risk of cancer. The psychological benefit has not been studied, but I would say most kids and most parents are unaware that this is going on. So I'm not sure that that is necessarily the biggest impact. Maybe when you get into puberty. So what about hormonal therapy? It's a little bit controversial. I would say historically this had been an idea. Well, why don't we give hormones to help descend the testes? This has been pretty soundly refuted as to be a benefit. There are side effects, including increased virilization, increased size of phallus, and aggressive behavior, and it's currently not being recommended by the American Urologic Association. So, you're seeing your patients in clinic, you're doing your well visits, you're doing general exams, you're not finding the testicle at 3 months, you've identified that it's not there, you're aware of it, you're documenting it. By 3 months, you should start thinking about referring. And that allows us, the consensus for elective surgery is that safety of anesthesia is 3 months and greater for term babies. So start thinking about referral at that point in time, understanding that when we do the orchidopexy prior to a year, we get the best outcomes. And this is another study that confirms that babies that were randomized between 9-month repair and 3 years of age repair, demonstrating that there's a greater volume in the 9-month repair of the testicle compared to the volume of the testicle of those repaired at 3 years. And there is a decline in the germ cells and Sertoli cells in babies repaired at 9 months, but a greater decline in those repaired at 3 years. So in 2012, the AHRQ did a systematic review on orchidopexies, demonstrating outcomes that testes could be descended to the scrotum in 96%, and that the surgery was safe for infants less than a year. The complications included testicular atrophy, less than 2%, reascent of the testes, again, just underscoring that you have to examine the genitalia on every well visit. Inguinal hernias can occur. I think the advent of laparoscopic interventions is going to change these outcomes the more, and I would say general surgeons use laparoscopy very frequently for pretty much every intervention we do, whereas urologists are not as facile with the laparoscope and may choose not to use a laparoscope for a palpable testis that's high, and this misses the opportunity to fix the inguinal hernia at the same time. Infection and bleeding are just routine complications that we have to talk about during an informed consent. How do we manage the kids post-operatively? No straddle toys, 2 to 4 weeks, no contract sports. And then we like to see patients within that month for an initial visit, and then at 3 months, 6 months, and annually. We do that because we want to assess for testicular atrophy. We want to assess for testicular volumetric growth. We want to assess for testicular masses and tumors. So these testes, once they're descended, still need close follow-up. When we don't find the testes, we've said, use the ultrasound, but what if the ultrasound doesn't find it? I would recommend avoiding radiation. No gonad likes radiation, and so MRI is really the better choice if you want to try to look for something that is intra-abdominal. However, I would say an MRI can be difficult to interpret in this regard, and the gold standard is really anesthesia, laparoscopy, and looking for the hardware, looking for the testicular vessels, looking for the vas deferens. If they don't have them, they don't have a testis. So that can be hard to figure out on an MRI. So I advocate for surgical assessment. And when we put in the laparoscope, sometimes what we'll see is, there is a vas, there is a testicular vessels, and the gonad is sitting intra-abdominal, depicted in this particular photograph. It's sitting right at the external ring. These can be very hard to get down. And I have, in my training, worked with urologists who just simply resect these because the risk for cancer, the risk for atrophy. Now, if you want to be aggressive, you have to do staged descent where you take 50% of the blood supply, move it as far as you can get it, wait, come back at another setting, try to move it again, to get it even further descended. And even though this might look like a hardy testicle, it looks like a decent size, we have all that data about testicular biopsies that show that this is not going to be a normal testicle. So I've seen, it's a little bit controversial, but I usually have worked with the urologist, and I get buy-in from the pediatrician, from the family, from everybody beforehand to say, we're in agreement, we've got to take this testicle out. Or if we're not in agreement, we take it down and we have to follow it very closely. So What about the retractile testes? Retractile testes are not undescended testes. It's important, and the reason that that's important to know, I think, particularly for the parents, is because there is no increased risk for malignancy in a retractile testis. However, I say there's no increased risk for subfertility. I would say that that is a kind of a depends on where is it located, because there is some data from the infertility clinics to say that men who have, retractile testes. I would say this is probably a problem with how we label these testes, and that a true retractile testis probably is going to be fine, but that some of the retractile testes are really undescended. And it's just hard to figure that out. If we biopsied every testes, we would know that. We've kind of gotten away from that. And so I think, the reason that this is kind of mixed data is because we don't have the right diagnosis. But you can see in these longitudinal studies of retractile testes that they don't get better. Let's say 30% of them don't get better. They kind of remain high. And those might be the ones that you want to just refer for orchidopexy. So there is educational materials that are available, written at the 5th and 6th grade level on UpToDate. This is really a summary of all the literature that's been compiled. I think it's a really good resource. I would recommend it. And if you're looking for materials for families, the UpToDate materials are easy to read and beyond the basics for families that want more education. And I would sit with families and review this information. Don't just send it home with them, so they can understand the terminology and what these things mean. So I've been a little bit quick in my delivery. I do have a clinic with patients. Unfortunately, they've got scheduled sometime around 8 o'clock. So I've been a little bit brisk in my presentation, but just to summarize, disorders of sexual development, think about that with ambiguous genitalia, those without bilateral, non-palpable, or unilateral, or a female with a very large clitoris, anything that just doesn't look exactly phenotypically like you expect. Think about DSD early, start the evaluation. Think about the ascending testis in any age. Be good about your documentation. Look at the genitalia, palpate it, document it, refer back to it when you see the patient again. Because the ascending testis is something that's preventable. When you start to see this was really easily accessible to the scrotum, and now it's not. Intervene at that point when it starts to become ascending. Smaller testes that might be atrophic, that's an indication that that testis did not descend properly and got hung up and just didn't develop. And again, the reason we want to focus on that is because we know histologically it's not normal. And if you find a mass in the testes, that's hard stop, and that's something that needs imaging and referral. So normal descent, generally complete by 3 months. Make adjustments for the premature. They need adjusted, corrected age. Changes in fertility occur after 4 months, if not descended. So we know we can impact that. We have a window of opportunity. Best opportunities before a year. Between a year and 2 years, we feel like we can have some impact. Beyond 2 years, we're not going to affect fertility. But we still want to descend the testes. We need to be able to examine it. It has an increased risk for malignancy. What happens when we do the orchidopexy? We reduce the risk for torsion, we reduce the risk for trauma, and we put it in a place where we can follow it. So the retractile testes, it takes patience to diagnose that. You've got to sit and hold that testicle in the scrotum for a minute or so, which seems like an eternity on a little child who doesn't like you to do that. But that's how you make the diagnosis. If you can fatigue the cremasterics, you can make that diagnosis. It's sitting high, you pull it down. It's sitting in the scrotum, you hold it for a minute or more. You release it, it stays there. That's a retractile testis. You release it, it rebounds up into the high scrotum or beyond. That's an undescended testis. So take a look at UpToDate for the exact literature references. It's very robust. There's almost 100 papers there. And the position statement on the use of hormones is available in the American Urologic Association website. And that is my presentation this morning. So I will stop here and open the floor for questions. What do you think?
I was just going to ask, do they know why the contralateral testes has decreased spermatogenesis?
Fascinating question. I really didn't dive into the literature on this. I mean, I know for years it was thought to be like antibody related, but really there were no antibodies that were identified. But I do think that there's probably a paracrine effect, because like the systemic hormones, kids with undescended testes are not, not virilized. They can look just like, the next guy with 2 testes down. So it's not the fact that they're missing circulating levels of the virilization hormones, but there probably is some kind of paracrine effect in that geography that might explain it. I don't know. I personally have not read the literature that defines this very well, but the outcomes are unequivocal. There is a higher rate of, for example, we are built with redundancy. And so if we lose a kidney, we can survive on 1 kidney. We have more robust reserve because we have 2 kidneys. The same is sort of true for fertility. We like to kind of reassure parents that, if we have a catastrophe like a torsion, we still have fertility. It's not a foregone conclusion that they can't have children. But, sort of the depth of reserve is diminished. But why there would be like an increased risk on the other side, I just don't have a good explanation for it. And I have not seen literature to really explain that. Yes, Dan.
So I'm just trying to reformulate a few things in my head. So I think I'll just make sure I get it right. And the difference between an intercanalicular testis and a retractile testis. I think you said if you can pull it down and hold it, and it doesn't bounce back, because then you're good.
Let me back up and focus on the words you used to describe that. An intercanalicular location, undescended testes. That is not.
So they could never be, testes like that could never come down. They're stuck there. Okay.
If you only find it in the inguinal canal, you might be able to pull it down, but if it, is sitting in the inguinal canal when you find it, that is not a retractile testis. That testis never made it down. And generally when you operate on those, you find this, they don't have the appropriate highway. It's almost like the highway didn't close. So the testis has nowhere to go. There's nothing open down there. There's no gubernacular attachment. It's like it just arrests. And the testicle, all that cellular programming to tell that organoid to move, it's not there. There's no gubernacular attachment, nothing. So that testicle is never going to come down. You've got to move it down. As opposed to the retractile testicle, which has gubernaculum, it's just long. And those generally, they're in the scrotum. They just sit really high. And you can get them to come down. And when you fatigue the cremus derrix, because you've held it there for over a minute, it stays there for a while until the muscle recovers. And then, depending on whether, and that's why I tell the parents, sit your baby in a warm tub bath, because that will generally relax everything. And if they can see the testicle routinely in the tub, it's not an undescended testicle. But if they can't, it's more likely that we're going to have to do something.
So the testes that retracts and sets high in the scrotum, and it really doesn't come down very much. That still needs to be approached.
I have done orchidopexies on kids whose chests, particularly bilateral, they're both sitting super high, and I follow them for a few months, and every time I see them, they're both sitting really high, and I don't like the size of them. They're small. I just put those down because I think we can do that safely. I look for hernia. I put in a telescope. I look for the hardware. Make sure that what I'm feeling is actually testicle, because you can get fooled by the gubernacular attachment, by kind of like, like a rubbery, subcutaneous scrotal tissue in a bulky kid. So I like to do a laparoscopic evaluation, and I look for the hardware. They got a vas, they got testicular vessels. I should expect a testicle there, and it should be normal size. But when I get small testicles, I get worried. When I have bilaterally small testicles and they're sitting really high, I like to descend those because I don't know whether I think I can improve the volumetric growth of that testy and improve fertility, because fertility likes this cool environment of the scrotum.
So you're really making me think. So I'm thinking about the wide range of normal that we see. So we see some newborns who have a very pendulous scrotum, and it's obvious. Some babies really don't have a very well-developed scrotum, and it's within the right range of normal, right? But you can easily feel the testes. So I'm just trying to think the development. Why is that like that? Should that must pendulous, perhaps, it's still rugated, it's still all that, and you can still feel the testes there. The variation that caused that.
Yeah, I think you just have to follow them.
Yeah.
It's just one of those things that it is within the range of normal variation, and you just have to see what happens to that testicle over time. And if you're never seeing it, if you never see it come down, like, by 3-4 months, start to consider an image or a referral to help you put another set of eyes on it and figure out, whether there's going to be a benefit to it. Yes, ma'am.
In the meantime, like when we're referring to you guys when we have these undescended testicles, is it helpful for you guys for us to go ahead and order the ultrasound in the meantime?
This is the point I was trying to make. I actually prefer to get the ultrasound because I think there's benefit in a pre-test question, and I also think it's important who does the study. So depending on where you're practicing, and the families will always say, do I have to go over here to get it done? I'd rather go here and get it done. And I always tell them, you have to go here. You have to come here because I can talk to the radiologist. I can see the image. The worst thing for me as a surgeon is to just get a report. It's great that it got done. I'm happy to see your report, but I want to see the image. That's going to tell me something. And it's a roadmap. And that's when I talk to the radiologist about the exam, that's what I'm telling them. I don't want to know what's in the inguinal canal. I want to know where in the inguinal canal. I want to know where the deep ring is, the internal ring is, where the external ring is, and where does it sit along there, because that informs me and helps me give an appropriate informed consent for the parents. Because whenever we talk about undescended testes and doing this exploration, we have to talk about the risk for orchiectomy, taking out whatever is there. And that's just an anxiety-provoking and, difficult conversation to have for parents. So I want to know what level am I at? Do I have to key in on that, or can I say I can feel the testicle, like we know from our, big AHRQ study, 96% of these are going to be able to be descended. But if I've got something at the internal ring, those are the ones that need staged repair. Those are the ones that are very sketchy that, and when you're doing like that Stephen Fowler's, that complicated staged descent, half of those don't survive. And so I've had parents with developmentally delayed kids who have made the decision, my child cannot undergo all these exams. It's very stressful for them. They don't want to be touched. I don't want them to have to go through that. I don't want to live with this uncertainty. I don't have a concern for fertility as a parent. I want you to take the testicle out. Those are important, high-stakes conversations to have. The radiology is really important. I don't like to have it done by somebody else. I want it done by a pediatric radiologist that I can talk to. So that's my bias. If you're in the system, I would prefer you to send it to me. I can talk to the radiologist and I can tell them, I need to know this, this, this. And then it's in the report. Okay. Well, thank you so much.
Thank you.